If you see or treat ACL tears, this is important. Now, if you're a surgeon like me who routinely performs revision ACL reconstruction, then this is key. After ACL reconstruction, not all second injuries are equal. Tearing your ACL graft is not the same as tearing the ACL in your other knee. Welcome to the Sunday paper roundup, where I read the paper so you don't have to. ACG. This week's paper is from the good folks at the American Journal of Sports Medicine based on data from the Moon Knee Group. Now this is important. The Moon Group is one of the most influential ACL research networks in the world. They followed thousands of patients prospectively for over 2 decades with high follow-up rates at 2, 6 and 10 years. This is some of the highest quality longitudinal ACL data that we have. Side note, the publication is out of Cleveland Clinic USA and I work at Cleveland Clinic London, so that's our mothership, and the senior author is my colleague and fellow caregiver, Kurt Spindler. But my interpretation could be biased, but watch on and hopefully you'll think me academic and fair. So what do? Out of 2,333 patients, they identified 267 who after primary ACL reconstruction went on to either have a revision ACL reconstruction or a new ACL reconstruction in the other knee within 5 years of their first operation, and they compare the outcomes. Importantly, both groups started at the same baseline, same age, same sex, same pre-op scores. This wasn't just sicker or more injured patients getting revisions. What did they find? Patients who had revision ACL reconstruction did worse. Worse function, worse pain scores, worse quality of life, lower activity levels, even years later. For example, IKDC scores were almost 8 points lower and cruise quality of life over 10 points lower. These are clinically meaningful differences. Now, the groups weren't perfectly matched surgically. The revision group had more allografts and fewer patellar tendon grafts at primary surgery and less lateral meniscus tissue removed. But the authors did adjust for this statistically, it's worth noting, and I'll come back to that. So the key message is, a failed ACL graft followed by revision surgery is a worse pathway than tearing the ACL in the other knee and having a primary ACL reconstruction on the other side. And that's a really important distinction. A key feature of the Sunday paper roundup is critical analysis. So let's look at the strengths. This was a prospective cohort design, a high follow-up of about 87%, multi-centered data with good generalizability, and moon-level data quality. The limitations, well, the follow-up from the second surgery is relatively short, median around 4.4 years. We don't know how these groups diverge or converge over the longer term. This is level 3 evidence, not randomized, and of course it can't be, but that matters when interpreting the conclusions. And all the surgical differences I flagged earlier, the revision group had roughly 3 times more allografts at primary surgery than the contralateral group. Allograft in young patients is a well-established risk factor for graft failure. There's a legitimate question here. Are we partly seeing the downstream consequence of our higher risk primary operation rather than purely the effect of the revision surgery itself? The authors adjusted statistically, but this residual confounding is real, and importantly, this does not prove causation, only association. For me though, the biggest limitation for a 2026 paper is this. The cohort is from surgery performed between 2002 and 2008. That's 20 years ago, before I even started orthopedics, when I had hair. Graft selection, augmentation procedures, rehab protocols, and return to sport criteria have all evolved quite considerably since then. So how applicable is this data to patients we're operating on today? The study also can't fully account for biological factors, technical factors, or the psychological impact of graft failure versus new injury. Losing confidence in a knee that's already failed you before is a very different psychological experience to injuring a knee that was previously normal. That may be significant, and it's underexplored in the literature. For me, this study reinforces something critical. Preventing ACL graft failure matters enormously because once you enter that revision pathway, outcomes are worse. So what's my verdict? Should you ignore it? Should you be aware of it? Should you consider it? Or should you just go ahead and change your practice? My verdict, be aware of it and let it shape how seriously you approach primary ACL surgery and risk reduction and how you counsel patients to tear their ACL again. Not all second ACL injuries are equal and the revision pathway is definitely the harder road. Stay tuned. I'll see you next Sunday. I'll keep breaking down the evidence as it lands.